So to start with, um, we know for sure by now that the epidemic of diabetes is increasing worldwide. So we have a significant increase in the incidence of diabetes during the last 2 decades. And this increase has been going on across all regions, all demographic groups, all ages, genders, races, ethnicities, and many subpopulations. And we know now that we have approximately 800,000 new cases of diabetes diagnosed in the US per year. And if you want to do global projections for diabetes epidemic, and that was an old study done in 2003, they projected that diabetes is going to increase all over the world. And this increase can be as low as 20% in Europe and 50% in North America, but can be as big as 105 or 111% in Eastern Mediterranean, Middle Eastern countries, and African countries. And one of the reasons or one of the explanations that can explain this increase is the spreading of the fast food in these Eastern countries. That is described by many authors, including one of my mentors and one of my professors called Dr. Ibrahim Salti, to whom I owe most of the slides on this presentation. He called this as McDonaldization. And most of the countries in Middle East, Eastern world, and African countries, they are subject to this increasing, effect of fast food. And another observation is that this increase in incidence of diabetes is observed in all ages, but more specifically, we are seeing more and more diabetic patients who are really as young as 30 years old. Now, why do we have vision loss from diabetes? And this can happen because of many factors, but the most common etiologies or the most common explanations are either bleeding inside the eye, and we call this vitreous hemorrhage. It can happen from retinal detachment, and we call this tractional retinal detachment. Or it can happen because of fluid leak inside the eye, and we call this diabetic macular edema. All of these are causes of vision loss from diabetes on the eye. And as you can see, all of these changes happen inside the eye, and specifically on this tissue called the retina inside the eye. That's why we call it diabetic retinopathy. Many studies have shown the effect of diabetes on the old studies to show you that as old as in 1970s, 80s, and 90s, we know that we can do few things to slow down the progression of this disease. Let's take, for example, diabetes control and complication trial. This trial has been conducted on diabetic type 1 patients, on 1,400 patients. And they showed that if we keep the blood sugar well controlled, like below 7 as H1C, and well controlled throughout the day, we have a better visual outcome, which means that the diabetes effect on the retina is not as bad as with patients who are not well controlled. We know this for a fact now. It's very well known. Most of the people who work in nutrition, healthcare, diabetes, endocrinologists, ophthalmologists, they all say to their patient, you have to tighten your glucose control so that you can prevent things from happening to your eye. Having said that, many patients don't know this. We need to tell them that whenever you have diabetes, control your sugar, and this will help you control your disease. Because no matter what we do as ophthalmologists, as eye doctors, if the patient does not control his sugar, then diabetic retinopathy is going to progress. And so for both type 1 and type 2. This specific study was done for type 1, but we know that the effect of type 1 is more dangerous than type 2 because they live longer with diabetes. If a patient was diagnosed with diabetes at the age of 10 and he's now 35 or 40, he's been living with diabetes for like 30, 40 years. That's a long duration. Okay. And the results, the results of this study, it showed mainly that we have a reduction in the development of retinopathy if we have a tight glucose control. And this is what I talked about right now. Let's jump to another study. This is the UK study. It was done on type 2 diabetes, and it showed the same thing. Intensive blood glucose control showed to have a significant reduction in development of retinal problems from diabetes and a significant reduction in all outcomes. We call them microvascular outcomes, which means that all the problems that comes from the effect of diabetes on small and fine blood vessels inside our body, including the blood vessels that we see in retina. The diabetic retinopathy study, similarly, it showed that early treatment for diabetic retinopathy is always favored over observation. Also, we know this for a fact now, but many patients don't know that, or many patients know it, but they are just reluctant to receive treatment. The treatment that we have now it varies from lasers, different types of lasers, and injections. And we talk about different types of injections too. But we know that if we treat diabetic retinopathy early on, we prevent vision loss, or at least we slow down the disease, and we can prevent vision loss in many cases. One of the results of ETDRS study is that it showed that aspirin did not help, but at the same time was not a risk factor for bleeding inside the eye. So diabetic patients can take aspirin without having the concern that this might increase the hemorrhage, the vitreous hemorrhage risk. But it did not help. Again, another study showing that decreased risk of moderate visual loss with early treatment, with early laser treatment. I don't want to bore you with all of these studies. I just want to show you that all studies like these show that early diabetes control, early tight control of sugar in the blood is really important to control the disease. And so the question that follows is, how often should I follow up with my doctor? And who should follow up with the doctor? Is every diabetic patient a candidate to follow up with his doctor? And when should we treat? So again, all of these are mainly scientific tables and quadrants, and I just listed them for completion here for any person who is really interested or who is in the medical field. It shows basically all different types and categories of diabetic changes. These are like standard photos, but I want to show you here like the classification. We start with like a normal retina. This is a normal retina. You can see the optic nerve right here. You can see the center of vision here, and you can see all the blood vessels really spread very nicely and with no hemorrhages anywhere. No, this here, you're talking about this. This is the center of vision, center of vision. If this is affected, most of your central vision will be affected. Okay, and all of this, all the rest of the retina is responsible for the peripheral vision. Okay. What is the reason? The reason so this is a normal retina. Nothing has happened yet. Okay, but if I continue, this is a mild disease. When we talk about mild disease, I wanted to show you a picture. I don't know why. Okay, I had pictures for mild, severe, and non-severe diseases to show you the difference. Okay, so if I show you this cartoon, it shows you all different types of changes that can happen at the back. Again, this is just for completion, but if you see here, you see different types of bleeding inside the retina. You see different types of lack of blood supply to specific areas that will die eventually. Yeah, these are the, here, like the yellow spots. This is like bleeding. This is another form of bleeding. These are new vessels that are forming, and these are really very advanced. And this is another type of diabetic changes on the back. What I want you to learn from all of this small talk is that there are risk factors that increase diabetic changes on the eye. And by knowing these risk factors, we can work on some. We can try to avoid some of the risk factors to have a better control and to slow down the disease progression. I want you to know what are the preventive measures that we can do and the frequency of ophthalmology visits. Let's start with the risk factors. We know that poor glycemic control, meaning that if we are not controlling the sugar level very well, the disease is going to progress. So this is in our hands. If we have a diabetic patient, we tell him that the better control you do, the better job you do in slowing down the disease that you have in the eyes. Okay? Duration of the disease. This is something that we cannot control. If a patient starts to have diabetes at the age of 10, well, we cannot do anything about that except treating him right now. But we should tell the patient, yes. Yes, so I'm gonna touch on that on the next slide. Hypertension also plays a role. So if a patient has hypertension along with diabetes, he has to control both. Renal disease. Again, renal disease might be a complication of diabetes, like can be secondary to diabetes. But again, having hypertension, having renal disease, having cholesterol, high cholesterol level, all of these play also negative factors. So we can control these. Pregnancy can exacerbate things. So if a pregnant woman has diabetes, she needs to get like a good glucose control and be followed out by her physician very carefully, because the baby who's growing really needs the sugar, but at the same time, high sugar level can be really bad for the patient, for the mother, and for the baby himself or herself. So the pregnant diabetes is the diabetes that develops when the patient becomes pregnant. And most of the times, this resolves after delivery. But some patients are diabetic before they get pregnant. So there are two different types of diabetes during pregnancy. Okay, if diabetes develops during pregnancy, this is usually a milder stage, but it should be followed up by an endocrinologist to keep diabetes under control. And usually it goes away after the patient delivers. Okay? Obesity, central obesity. Very important to control diabetes. And eating disorders. Some patients have some eating disorders, so they tend to eat so much and like get long times of starvation. This is also bad, because if you have a dropped blood sugar, this is also bad for the retina and for the brain, because you don't want to drop the blood sugar to very low levels, because at this time the retina will also suffer from lack of appropriate nutrients. How do we do the preventive measures? As you asked, three main things. First of all, we have to watch our diet. And it's not easy, I know, especially in this world. What we have to do, we have to seek help sometimes. Seek help from specialists, from nutritionists. Nutritionists are meant to give you like a schedule that you can follow, and this will help you get your blood sugar level really well controlled. And by diet, I don't mean starvation again. Starvation is as bad as having high blood sugar level all the time. So you have to have like a regulated schedule of balanced, well-balanced meals that gets you all the appropriate nutrients that you need for your body, but at the same time, keep your blood sugar well controlled. We know that diabetics cannot control their blood sugar by only diet, except in very early mild stages. We call this now prediabetes. That's why medication are very important for these patients. And some patients, they have the tendency of, whenever they have like a long duration of controlled blood sugar, they just think that they control the disease and they start skipping their medication. This is bad because what's happening is both you're doing your part by controlling your meals, but at the same time, the medication is helping you. So medication that are well followed by your primary care doctor or by your endocrinologist is also very important. So it's mentioned in this picture. They are saying basically insulin, but we talk about all kinds of medication nowadays, not only insulin, right? So all kinds of medication along with healthy, well-balanced meals, along with exercise. Exercise is very, very, very important for these patients for multiple reasons. The first reason is that it stimulates our muscles to take up blood sugar from the sugar that is circulating inside your blood. It also stimulates insulin release. And it allows you to lose some of your fat and some of your blood sugar that you have along the process of exercise. So exercise is very important. Again, we do not have to overdo this. We're not talking about like 3-4 hours of exercising per day. We're talking about 40 minutes, 40 to 60 minutes of exercise on a daily basis. You can do any kind that is suitable for you. Just, yes, like treadmills. You can walk, but it should be a fast walk. Like you cannot just, a fast walk, yes. It should not be like a slow walk for like 20 minutes and a relaxing walk. No, this is not enough. You can do running if you tolerate it or if you like it, especially for young patients who are like 30 and 40 and they like to run, they can do running. But what's required is to get your cardiac system to work more efficiently. So you have to do something that gives you, that gives this adrenaline rush. So either a fast walk for like 40 to 60 minutes, as I said, or having to run for like a few minutes and then relax, run, relax, run, relax. There are several types of exercise, but I would encourage any type of exercise that allows you to feel that you did some extra work, okay, during the day. No problem, no problem. Ask your question. So it depends on the patient. Yes, yes. So if you do your daily life activities, you do it at a stage where your metabolic rate burns like an X amount of calories per day, right? If you walk without getting yourself a little bit more active than you usually are, then you're not getting your metabolic rate higher. You're not pushing your body to do anything more than it usually does. It basically depends on what you tolerate doing. We cannot ask, for example, a 90-year-old man to do what a 30-year-old young person can do. So whenever a person comes to me and asks me about specific exercises, I tell him just do things that can activate your body, that can allow you to feel that you're doing something more than your daily life activities. Again, swimming, like for example, swimming is an excellent exercise, but many patients cannot tolerate swimming more than 10 minutes. And if you swim for 10 minutes and really get yourself exhausted and afterwards you're not doing anything, I don't think this is a good type of exercise that you're doing. Mhm.
Maybe it is false.
No, no. Any type of exercise that gets you a little bit tired is fine. Any type of exercise. So some patients say that at my age I don't think that I can do exercise. This is not true. Um, just because you spend like the last 1 or 2 decades not exercising and you're out of shape, it does not mean that you cannot do exercise anymore. What's usually advised is to start your exercise at a slow rate and then increase it slowly. Like for example, if you can do fast walking, okay, for 10 minutes, and these 10 minutes gets you tired at the beginning, you can uh, just do that for now and try after like a week from doing this to increase the duration to 15 minutes. If this works, then perfect. Every week you can increase 5 minutes until you reach your 40 or 60 minutes. It's just a matter of, building your stamina back. Mm-hmm. Yeah. Okay. That's fine. Okay. And you do it once a day? It's not bent with sugar, but all types of exercises are good for blood pressure control, are good for cholesterol control, are good for diabetes control. As long as long as your walking is allowing you to do something to stimulate you more than what you do usually on a daily basis. Like if you walk 1 mile in 15 minutes, this is a very slow walk, right? But if you walk slowly 10 miles in 10 minutes, that's a very fast walk, right? So do something just more than what you're used to do, a little bit faster than what you used to do. Okay? It's the same. It's the same. Yeah. Yeah. It's the same. But we have a good weather now. You can walk outside. Okay. Uh, how about examination frequency? If a patient is diagnosed with type 1 diabetes, and usually this type of diabetes affects the young patients, okay, at the age of 9, 10, 11 years old. Uh, when the patient is first diagnosed, he should have an ophthalmology um, um, examination within 5 years and then once every year. So examination frequency is how many times you should visit your eye doctor if you have diabetes. So if you have diabetes, you have to visit your eye doctor once a year, unless the doctor specifies for you that he needs to see you earlier. But the minimum required nowadays is once a year. Yes, ophthalmologist. Yeah. For pregnant women, they have to go before planning. So if they are planning to if a woman is diabetic and this woman is planning to get pregnant, she has to consult her endocrinologist or primary care doctor and her ophthalmologist before she gets pregnant, like pre-plan it. And once she gets pregnant, she has to go to her ophthalmologist 3 times during pregnancy. So once every trimester. And she has to go one last time 2 months after delivery. Okay, so 4 total visits or 5 total visits if you want. Okay, questions? Yes. So when you have diabetes on your inside your body and your system, diabetes means that you have a high glucose level circulating in your blood, in your veins and your arteries. The sugar that is very high inside your vessels, it will get stuck on the periphery of these vessels. Okay? And because this accumulates with time, these vessels become abnormal. The first vessels to be affected are the small vessels. And that's why the small vessels in the kidneys and the eyes are the first to be affected. Okay, they start to leak and they start to bleed. And eventually, when the organ does not receive enough nutrients and enough oxygen because the vessels are leaky, then the organ develops new vessels to try to protect itself. We call this neovessels. And these neovessels are dangerous to the organ because they tend to grow in abnormal places and they tend to bleed and they tend to leak much easily than the normal vessels that we have. And this creates bigger problems at the level of our retina inside the eye. Yes, yes, yes. He should be checked whenever he's diagnosed, once within 5 years out of diagnosis, and then once every year. But yeah, he should be checked. Yes. It's most probably it's going to stay with the baby, yes, for the rest of his life. It depends why the diabetes happened at this very young age. But usually, yes, it stays. It's outside my scope because this is something that concerns the endocrinologist. Um, I don't want to answer something that I'm not really confident answering. Yes, yes. No, no, no. It can affect any organ, but the eyes and the kidneys are the first to be affected. So there are two ways to measure sugar, right? We have either we can get it directly from on a daily level, and we call this either fasting sugar or post-meal sugars. Or we can get something called HbA1c. The HbA1c is basically measures how was your diabetes doing for the past 3 months. And the meals or the fasting sugar, it measures on a daily basis how is your sugar doing. The fasting basically when you wake up in the morning and having not eaten for 8 to 10 hours and you do your blood sugar level, this should be less than 108 and 108. Anything below, for fasting sugar, it's anything below 108. For HbA1c, it should be less than 6.1. No, no. 130 is, this is for meals, for meal sugar level. So if you are throughout the day and you take your sugar, it can be anywhere from 100 to 200 and it will be normal. For fasting should be less than 108. For HbA1c should be less than 6.1. The 130 that you're talking about most probably is the LDL level. That's cholesterol level. No, no, with medicine. For diabetics with medicine, yes. If the patient is not diabetic, of course, he's not taking medication. So, the work darkness does not describe anything. So, I really cannot answer this question unless I know exactly what's happening inside your eye. So I need to examine the eye so that I can answer this question. ما الزرقاء is in English, it's called cataract. So the cataract is something that we will all develop with time. And uh, the cataract is, we're all born with like natural lenses inside our eye. And this lens is transparent. With time, this lens becomes opaque. And the more opaque it gets, the less vision clarity you get. Colors will become dim, the vision will become poor, and you will have glare at night, especially when you're driving at night and another car hits your car's light hits your face, then your vision is going to be really affected. This is if you're not feeling this and cataract is not advanced enough on eye exam, usually we tell the patient that you can wait. There is no drop to the point that improves the cataract. Cataract develops with time, it's inside the eye. There are no drops now that improves the cataract. If he tells you to take one drop and it's a medication, it's a prescribed medication, this is something else. He's giving this to you for something else, for another condition. Yes. Yes. Some patients can get it earlier because of other reasons, like for example, trauma to the eye, or steroids if they are getting steroid drops or nasal sprays, um, or if they have any kind of systemic disease that's affecting the eye too. But usually it gets during the 60s and the 70s. Yeah. If the allergy was treated for a long time by steroids, it can cause cataract, yes. But if it's, yes, so steroids is the culprit here. It's not the allergy. Allergy does not cause cataract. It's a steroid that causes cataract. Yeah. A virus, okay. Okay. Good. Yeah, it does not. It depends. Some patients, their cataract worsen very fast. Some other patients, it takes like 10, 15 years. Maybe sometimes you would never need to do a cataract surgery. It depends on your daily life activities too, to be honest. If you are not bothered and you're seeing things that you need to see on a daily basis, like the TV, driving, signs on the streets, there's no glare at night, then you really don't need to do a cataract surgery unless on exam we're seeing that the cataract is doing something bad for the eye. Then we tell you that, well, we need to take the cataract out because it's hurting your eye. Or if we really want to examine the back of your eye and we cannot, because the cataract is like an opaque shield that is not allowing us to see what's inside the eye, then we tell you that we need to take this out. I live in Dallas, yeah. I live in Irving. Yeah. Yeah. I can see it now if you want. Yeah. That's fine. Usually I come in the evening, yeah. At Aisha, yeah. On a daily basis almost. I'm currently doing my fellowship in UT Southwestern, so it's the last years of training. It's a subspecialty. And it's in UT Southwestern in Dallas. But I come here almost on a daily basis. Sometimes it helps. If you have a disease inside the eye, glasses cannot help. If your decrease in vision is because of a disease inside the eye, whether this is cataract or diabetic changes inside the eye or retinal problems, glasses will not help. But if inside the eye is really good and there's only like early cataracts, nothing else, then changing the glasses might help. It depends. No. Dry eye is something on the surface. Cataract is inside the eye. There is no relationship. You can. Artificial tears, yeah. There's no side effects for those, yeah. It's basically the composition, it's a very close composition to the tears, so it's very healthy for the eyes if you use them. The only drawback for those is that sometimes they come with preservatives in them. So if you use them more than 4 or 5 times and they have preservatives, then on the long run, you might cause more harm on the eye rather than helping them. So you can do either one of those two things. Either use them less than 4 times a day, and you should be okay. Or if you use them more than that, you can get the artificial tears without preservatives. Every brand has both, has the preservatives and without preservatives. Yeah. 1 drop in each eye 4 times a day. Or you can get the preservative free, and then you can use them as much as you want. You're welcome. Yeah, diabetic retinopathy. Retina, yes. Sometimes, yes. Yes, there is an entity called age-related macular degeneration. Sometimes the center of the vision degenerates because of age and sunlight exposure. Sometimes smoking can affect that. Genes can play a role too. Yeah, we can get decrease in vision because of that. In cornea, cornea, cataract refractive surgery. Yeah, exactly. No, it's a fellowship practice. When you do our fellowship, we don't have our practice yet. Usually 1 to 2 years, yes. Yeah. Thank you. Thanks, of course. I'm ready to help anytime. You're most welcome.